German. My Spanish is very bad, so I will not speak in Spanish. My excuse for that. I will follow the previous presentation, and we have heard a very nice presentation this morning about cartilage repair. But what we haven't heard is evidence-based medicine. Evidence-based medicine is something that we need. And we have also heard that it's very difficult in orthopedic surgery and for orthopedic surgeons to get any evidence-based medicine. So let me try to reflect any evidence-based medicine on this prospective study that I will present for you. This is the study that was just mentioned, the Chondrocelect implantation compared with microfracture. But first of all, and this has been mentioned this morning, why are we doing cartilage repair? Is it sense? Is it senseless? It was mentioned. These publications are out there. Should we do any cartilage repair? We do it for patients having pain. They are having pain due to the cartilage lesion, and they also have a diminished function of mainly the knee joint. So these are patients that we want to treat, and we think that we are doing the good things by any conservative treatment. This was mentioned very nicely by the invited rheumatologist this morning, and also by different surgical techniques that we have seen this morning, and you will see them all this afternoon as well. What's very important is we should perform a good clinical practice. It was also mentioned by the previous speakers. A good clinical practice means that there is no standard treatment for a cartilage defect. Every patient should be investigated individually. So this is very important. And why do we treat these patients? Because they have pain and diminished function. They are young patients. And we believe, this was discussion just before lunchtime, we believe that we are preventing any osteoarthritis, so that we have to perform prosthetic surgery in the young patient. And young is very relative. Young is today up to 45, 50 years, I believe, even higher. So we should try to prevent this early, bigger surgery by performing cartilage treatments. And this is why we should stay, that's also been mentioned, this is a short repetition, we should stay in the envelope of function. We should first look at the alignment, because we are talking cartilage and nice congress. We should first look at the alignment. Then we should look at the ligamental stability. Then we should be sure that the meniscal integrity is there. And it's after these exclusion and exclusion criteria that we may look at the cartilage. Before these three parts haven't been excluded, we may not treat any cartilage defects. So if we are in a malaligned knee, if we have a torn ACL, if we have a meniscal deficient knee, we are not able to look at the cartilage, because we first of all have to restore these three things. And these are getting out of the envelope of function. So we should get into the envelope of function before we treat any cartilage defects. It's getting much more difficult when we are dealing with the patellofemoral joint. It was also open for mention. And I think that the indications of cartilage treatment is much less present in the patellofemoral joint. We have several things that we should look at, as you see here on this slide. So the study hypothesis of this prospective study was as mentioned. At 12 months, we want to have a structural superiority. Histology. What means histology? It was mentioned in the morning session. A lot of histology. What does it mean? We believe that a good structural superiority means in long term that we will have a better clinical outcome. So let us look at this in detail. It was a prospective, randomized, multicentric study where about 110 patients were included. It's not easy to include 110 patients because the inclusion criteria were very strict. We had biopsies of almost all the patients at 12 months to look at the histology of the microfracturing group and of the Chondrocelect or cell transplant. group. And we also followed the patients up to 5 years. And you see that 77 patients were followed up to 5 years or 60 months, that you will see later on the slides. So why were 17 patients failed? Because 7 of the patients that got the cell transplantation, they had a failure, they had to be reoperated, and 10 of the microfracturing patients, they also had to be reoperated by the means that you see on the slide. 18 patients discontinued the study for several reasons. Some of the patients didn't follow the restrictions of the follow-up program, and some of the patients just withdrawn. They weren't interested anymore. And this was also mentioned by one of the previous speakers this morning. Maybe they were good, and keeping good patients, was it from microfracturing or cell transplantation, keeping good patients in long-term clinical study is not easy. This is just a short slide showing the demographics of the two groups. The two groups were completely comparable. Sex ratio, BMI, age, everything was looked at in detail, and they were completely comparable. So this is very important if you look in the following slides where we can do the clinical outcome. But as I mentioned, we wanted to, first of all, our primary outcome was a histological superiority of the cell transplant group compared to the microfracturing group. And this you see here on this slide. We published this in the American Journal of Sports Medicine in 2008, where we had a superiority, histological superiority on the cell transplant. And these are validated histology score. We see the histological score. We have a significant superiority of the cell transplant. And we also use the ISRS type 2 scale to look at all the subgroups of histology. And you see on the left hand of the slide the immunostaining of collagen type 2 and collagen of the cell transplant, the right hand side of the microfracture. So that was a superiority. Our first goal was reached in this study. The second goal was, well, we have a superiority on the histology. Then we hoped that the clinical outcome will be better on the long term. And we saw that if we're looking at the COAST score, the clinical outcome of osteoarthritis score, we saw that in 3 years, the overall COAST score had a superiority, was non-inferiority, but was better than the microfracturing group at 3 years. So this was, well, it's not a long term, but I will show you the 5 years data, but at 6 months, we had a superiority. Here it is, the 36 months. And remember, what you see on this slide is that you see here that there is difference on the in the green, the cell transplants, and in the red, the microfracture group. And you will see that this remains. It doesn't change enormously. So once we have obtained the clinical result at 3 years, we could hypothesize that this clinical outcome at 3 years will remain the same. You see, even the microfracture will remain the same, but the cell transplant as well. And we see, and this is probably the most important slide of my presentation, dear colleagues, that if we treat patients before 3 years of onset of clinical outcome, we see that there is a significant difference in the COAST score between the two groups. So the message, I believe, is to treat the patients before we reach the period of 3 years of clinical outcome. To treat the patients earlier. You see the difference here on the left-hand slide. You see this clinical difference, and if we treat the patients in the chronic lesions, we don't see any difference in the two treatment groups. So this was quite apparent in this study. What were the possible factors involved in the failure of these included patients? Probably previous surgeries. Probably absence of calcified layer or tide mark. This was saw at some of the histology studies. We have also noticed that the microfracturing group, they failed earlier than the cell transplant group. And also there was a difference in post-failure options. This is a heavy slide. We will not stay on this. We see only we have some cartilage hypertrophy in the cell transplant groups that we didn't see in the microfracturing group before, because in this prospective study we used periosteum. It was not used in the later part of the enrollment, but in this study we used the periosteum, and we know that there is more hypertrophy on the use of periosteum. So what is now to finish, ladies and gentlemen, the perfect or the good, we believe, not only for CCI, for cartilage CCI patient group. We should have the ideal patient. We should have the ideal lesion. We should know the contraindications, and we should also have the golden standard. The ideal patient is a symptomatic patient. We don't treat a lesion that we just find during arthroscopy, because we find a lot of them. We treat the full thickness, chondral, osteochondral defect. The ICRS scale has been described for you this morning. The surrounding cartilage should normally be healthy, and we should also stay in the envelope of function. We also know that the ideal lesion is more than the exception. Trying to find the ideal lesion is not easy. Many lesions occur in pathologies, in knees with concomitant pathologies, and some of them have degrees of uncontainment. So this makes it more difficult. We know that contraindications, the osteoarthritis, the inflammatory joint disease, the envelope of function, don't forget this. This should be known. And the golden standard, we perform an arthroscopy all. Because imaging and arthroscopy, the reality is so different. And we show the exact location of the lesion, the depth of the lesion, also see the size of the lesion after debridement, degree of cartilage undermining. We could look at the status of the meniscus, status of any repaired tissue. So this is very important. And I would like to conclude, ladies and gentlemen, that in this prospective study, we have shown the primary goal, the structural superiority. We have shown that at 5 years follow-up, there is a clinical superiority compared with microfracturing, but still, and I think that in the future this will be shown more and more, that try to treat the patients before the lesion gets chronic, because you will have better results. I do thank you for your attention.